Hello again, Lesson 4, Part 3. I'm going to wrap this up by continuing Joe's story. Let me make a couple of comments first about the dosing of your statin drugs. I mentioned before that atorvastatin has the highest potency per milligram dosing, and that some of the others you may have to give more milligrams to get equivalent dose, and even at that they can't quite reach the higher levels that the atorvastatin does for high intensity therapy. That said, depending on pricing and availability and patient preference, sometimes we go with the other ones, as I mentioned, the pravastatin being a nice choice if there are multiple medications and you're worried about polypharmacy and the cytochrome P450 system interactions. So let's think of atorvastatin, and when we try to decide which dose to start with, and the recommendation being moderate to high intensity therapy, an easy way to figure this out instead of memorizing numbers is to look it up in Hippocrates and see how high the highest dose is recommended for the drug. So depending on which drug you choose, it may be 80 milligrams, it may be 140 milligrams for another, or whatever. But that would be your high intensity, and then moderate would be some kind of, kind of the recommended middle dose. In the case of atorvastatin, with him, probably would start him at 20 milligrams and boost him to 40 to 80 eventually. I'm trying to push him up to 80. We don't monitor lab values for cholesterol over time. It's not recommended anymore to titrate the drug by lab values. We just go with what we know his best recommended therapy is in terms of low intensity, moderate intensity, or high intensity, and we try to push him to the highest dose we can without hurting him. And we have to figure that out by side effects and also by looking at his safety labs or his liver enzyme functions to make sure that they stay within range. That's the biggest worry about these drugs. So probably going to try to get him to 80 milligrams of atorvastatin at some point, but we'll start lower. If he was older and a little smaller and maybe a small female or something weighing 100 pounds, I even start with 10 milligrams sometimes just to see how they tolerate it. Patients can also cut these pills in half and start at a lower dose just to see how. It's recommended we give these drugs at bedtime because they seem to be absorbed better in the overnight hours. So what if this happens? 5 years go by and you get facts about Joe. He went to ER, he had a chest pain with exertion. He was admitted for observation and a myocardial infarction was ruled out. He had a stress test and he has stable angina or angina. You might have guessed that just by the description of his pain with exertion. So we might expect cardiology to prescribe a medication to be used as needed in his case. I'm going to give you a tip-off here. It's going to be a short-acting nitroglycerin, a sublingual probably. There is a spray as well available. It's more expensive, but the sublingual nitroglycerin is used in cases where we have this anginal pain with exertion. So I think in the time past we used to think that this drug dilated the coronary arteries, and it's not really so. It does, however, cause vasodilation in the periphery, and thus reducing the preload onto the heart, so the heart has less work to do, and it can kind of recover from the kind of short-term lack of oxygen, probably caused by blockage of the arteries, probably secondary to his hyperlipidemia and tobacco history, etc., etc. At any rate, these drugs are doing this, and as such, of course, they lower the blood pressure as well, which makes sense. You're reducing that peripheral vascular resistance. So it would follow then that the precaution and caution about this drug's use is going to be that the patient may drop their blood pressure quite a bit and be dizzy. I'm going to ask you to look up how you're going to carefully instruct the patient as to exactly how to use this drug and what to do if the drug doesn't work, and what other things must happen during the time they are using this drug. And I'll have you do that as a little sidebar, and I'll post a little answer to that question as the week progresses, as we get closer to next week. Oy vey, another 5 years goes by, you receive a report from the hospital. Joe, and meanwhile, you're hopefully following Joe all along, and he's doing what he should do, but he's now had a ST elevation myocardial infarction, so it's called an STEMI, and he's been diagnosed with heart failure. This link takes you to the YouTube. I'm not going to go there right this minute. You can do that yourself. It's in your reading. And it's a great little primer about systolic heart failure, which is the more common form of heart failure that you're going to investigate as you do your heart failure mind map. So as you do the heart failure mind map, and I did post some instructions on this, you want to explore and map out briefly the pathophysiology. In his case, he's had myocardial damage, and therefore the heart pump is not functioning effectively because of damaged heart muscle. And determine, in his case, whether he has preserved ejection fraction or reduced ejection fraction. These are the new terms we now use. We used to use left-sided and right-sided heart failure. We then now have come to systolic and diastolic heart failure, and we also can refer to reduced heart failure. Reduced ejection fraction, or RUF, as we say. These are the folks with systolic failure, and those whose ejection fraction is preserved, and they are diastolic failure. Their heart muscles thickened and stiff, but their ejection fraction is preserved. So those are HUF, PUF are the preserved, and HUF, RUF are the reduced. And so your heart failure mind map should really address the so what, especially around pharmacology therapies, which of course is what this course is about. So our goals of treatment and our mechanisms of action, and why we would use the various drugs we use in the heart failure patient. We've already mentioned one of them before, being furosemide. In addition, of course, you will see that we've also talked about ACE inhibitors, and those are a big part of the picture as well. In this algorithm, which is in your reading in the Yancey article, it talks about the recommended therapy by stage, and you can use this to guide you in terms of your mind map development, as well as tuck it in a folder, because this is going to be great for use in primary care as time goes on. Primary care providers are probably going to focus mostly on stage A and B. As we get into C and D, we're going to definitely have ongoing interaction with cardiology, whereas in A and B, we might deal with the patient a lot in primary care, and just, especially in A, and then refer them for the diagnosis and assistance, but we're going to manage them more. C and D, we are not going to be managing per se. Stage D, refractory, of course, is end stage. This little cartoon just gives you a hint about the various drugs which you've already met a few of. The ACE inhibitors, alpha blockers we've talked about briefly, the nitrates, and we'll talk in a second about digoxin. The beta blockers, which is protective of the myocardium, and as I mentioned earlier, will probably be one of the drugs that Joe gets prescribed by the cardiologist following his STEMI. And of course the diuretics, particularly furosemide. So what about digoxin? You've heard about it, you've kind of heard it as in your nursing background as that scary drug with lots of side effects. And so forth. We do still occasionally see it used in refractory systolic failure. It's less and less used as we have better drugs available. However, this is a drug with a very narrow therapeutic index. And so you know what that means. Dig levels have to be monitored on a regular basis, and we have to be really careful about toxicity at the high end, and of course effect at the low end if we don't have enough drug on board. So this is one of those drugs that is just going to require tons of monitoring. It's fallen out of favor because newer drugs have come along, but it is one of the oldest drugs around. It's actually developed from the foxglove plant, as you know from your history. And when you think about any drug for heart failure, thinking about what are the goals of treatment, we can't necessarily always reverse the damage that's been caused or anything like that, but we are trying to preserve cardiac function as long as we can and prevent remodeling to continue to occur in the cardiac muscle. So now you will have available soon the student presentation posted on the discussion board for presentations, and you will discuss the problems of atrial fibrillation, which is seen very commonly, and the medications used in the management of this problem and its potential sequelae. So thanks a lot for listening. This is the end of the formal lessons, and I will see you online.